Hello, everyone, and welcome to another TP recap session. My name is Ibrahim Omer, and I'm very glad to be facilitating today's session. On today's session, I'll be joined by my very dear friends Anmo, Jimena, and Elena as well, who will go on introducing you guys to a variety of subjects that we have had on cases presented on VMR before. So starting off, we're going to start off with Anmol. So Anmol, if you'd like to introduce yourself to the audience and then start off with your presentation.
Thank you so much. So good morning, good afternoon, and good evening to everyone. My name is Anmol Preet Kaur, and I am an ECFMG certified international medical graduate from India. And I'm a CP Solvers Academy member since December 2023. And this is my third Teaching Points recap presentation. And this time as well, I have chosen a difficult topic, at least for me. So let's see how it goes. So now, okay, so now should I share my screen now?
Yes,
Okay.
Go ahead, Anmol.
So the title of my presentation is The Story of Blood Cancers, that is leukemias and lymphomas. So basically, in March, we had many cases which were actually related to blood cancers. Namely, they were on March 3, March 7, and March 20. So the diagnosis of those cases were T-cell prolymphocytic leukemia, mixed phenotype acute leukemia, primary pericardial Burkitt's lymphoma. So this will be the my main focus for the presentation, as I wanted to recap leukemias and lymphomas. So to recall the cases, let's visit the problem representations of these cases very rapidly. Okay, so the first case, these are the ages of the patient. The first case was a 30 years old lady who presented with a complaint of dyspnea on exertion and non-productive intermittent chronic cough. Both of these present symptoms were for 3 years, and now since 1 year, the cough had blood in it as well, and all of these symptoms were unresponsive to steroids. And also, the patient was an active smoker for 15 years. Then another thing was that the patient had leukocytosis with neutrophils and lymphocytes, and SIL2 was increased. And these were the CT findings for the patient. And FACS, BAL, bronchoalveolar lavage showed double positive cells, CD4 and CD8. And there was increased proliferative activity of T cells and co-expression of TCL1 on T cells. And FISH results showed CD4 plus, CD8 plus, CD52 plus with TPLL typical translocation. Why I have mentioned all of this? Because this all is very much key to the diagnosis. And it was realized that the pathologic T cells only infiltrated the lungs, causing the respiratory symptoms, and the patient was diagnosed as a case of T cell prolymphocytic leukemia. Similarly, our second case was a 71 years old man who came with like two localized unrelated symptoms, which were left ear pain for 2 months and right leg swelling for 1 week, with dyspnea on exertion and dry cough. Right leg swelling was mainly thought to be DVT, and it actually turned out to be DVT only. But the left ear pain, we could think about otitis externa. And what do we mainly cover for otitis externa? We cover pseudomonas with ciprofloxacin, but there was no response to ciprofloxacin as well, and this patient also had a smoking history. Interestingly enough, the patient had a large leukocytosis with monocytosis and lymphocytosis, but later on it was realized that the lymphocytes were actually blast, and that is because of an automated error which can happen. So basically, we know that all the lines were normal 8 months ago. So what do we classify it as? We classify it as acute leukemia because all the lines were normal 8 months ago. And upon immunophenotyping, it was realized that the leukemic cells were both of lymphoid and myeloid lineage, and therefore the patient was diagnosed as a case of mixed phenotype acute leukemia. Our third case was a 59-year-old man who presented with progressive dyspnea for 4 weeks and lower extremity edema with weight gain for 4 weeks as well. Interestingly enough, 4 weeks ago, the patient had a cold. And along with that cold, he also had pericardial effusion. Therefore, he was treated empirically for viral pericarditis. But also, the patient had increased troponin and increased BNP levels. The increase in troponin was flat. Therefore, the patient was also thought to be having myopericarditis. And there was increased JVP. Also, this patient had a smoking history. And again, we have increase in WBC with neutrophils. And also the patient was found to have exudative pleural effusion, mildly reduced ejection fraction, and inflammatory constrictive pericarditis. And on CT abdomen, it was found to have GIT involvement as well. So therefore, biopsy was done from pericardium, and the patient was diagnosed as a case of primary pericardial Burkitt's lymphoma. So these were some problem representations. If I want to know that, what do you mean if I say leukemia or lymphoma? What do we mean by that? So basically, they come under the big spectrum of blood cancers. Basically, leukemia is something that originates from bone marrow, and lymphoma is something that originates from the lymphoid tissues. And they come under the umbrella of hematopoietic neoplasms. But if we want to discuss about that, it's important to go back and understand how the cellular component of blood is formed, how are RBCs formed, how are all these things formed. So this is a picture I took from Wikipedia, which starts from, this is how all the cells of blood, they are formed. Here we can appreciate that multipotent hematopoietic stem cell divides into common myeloid progenitor and common lymphoid progenitor. And there it can form platelets by this way, then erythrocytes, and then we have the granulocytes. This all is the myeloid lineage. And here we have lymphoid progenitor, which can give rise to lymphocytes, be it T lymphocytes or B lymphocytes. And this is our lymphoid lineage. So just having this basic concept in our mind, we can think towards the next direction. So that's how I wanted to just show myeloid lineage and lymphoid lineage. This will be very, very helpful in next slide. Now, if I talk about hematopoietic neoplasms, I honestly never understood this topic because of the so big classifications we have, and I tried to concise it. So many classification systems have been devised over the years, but the current accepted ones, they are International Consensus Classification and World Health Organization 5th edition classification. How do they classify the hematopoietic neoplasms? Number one is myeloid neoplasms, affecting the myeloid lineage, as you remember from the previous slide. Next is lymphoid neoplasms, obviously affecting the lymphoid lineage. Number third is myeloid and lymphoid neoplasms with eosinophilia and tyrosine kinase gene fusions. Number four is mastocytosis. Number five is histiocytic or dendritic neoplasms. And the next one is mixed myeloid and lymphoid neoplasms. This is still a very condensed classification. But for the scope of this presentation, I just wanted to simplify it a bit. So we will consider only three classes, that is myeloid neoplasms, lymphoid neoplasms, and mixed myeloid and lymphoid neoplasms, just to make the study of the cases easier. So again, myeloid, lymphoid, and the mixed one. Also, another way to classify them is saying that if it is acute leukemia, acute or chronic leukemia. Acute means sudden onset and rapidly progressing, and chronic means gradual onset and slowly progressing. So just keeping this basic concept in our mind, we can think about these classifications because myeloid and lymphoid, they don't just end here. They have another whole spectrum. Talking about the myeloid neoplasms, we have mainly four categories. Number one is myeloproliferative neoplasms, which, as the name suggests, means proliferation of the myeloid lineage. Number two is myelodysplastic neoplasms, which in the next presentation, Alina will tell us a lot about it. And number three, we have the combination of myeloproliferative and myelodysplastic syndromes, which basically has proliferation and dysplastic features both. And number four, we have acute myeloid leukemia. So just to make some more clarity on myeloproliferative neoplasms, if we have proliferation of megakaryocyte thrombocytes, we have essential thrombocythemia. And for erythrocytes, we can have polycythemia vera. And then if we have the accumulation or the increased number of granulocytes, then we have chronic myeloid leukemia. So these are basically all types of myeloproliferative neoplasms. Then if I just now talk about the lymphoid lineage and the lymphoid neoplasms, how do we classify that? We classify that on the basis of T cells and B cells. So like this, the involvement of T cells and B cells, but also we, in these classification, we make note of if it's affecting precursor T cells or B cells or mature T cells or B cells. So this is common to both of them, precursor or mature. And precursor, by precursor, I mean T lymphoblast or B lymphoblast. So if I want you to make a guess, what could affect precursor T lymphoblast or precursor B lymphoblast? It is definitely acute lymphoblastic leukemia, be it T acute lymphoblastic leukemia and B acute lymphoblastic leukemia. So this was just a basic, my trial to just classify it. And if I want to concise it on the page, then if we are saying myeloid, lymphoid, and mixed myeloid, myeloid and lymphoid neoplasms. So number one, just to revise, myeloproliferative, CML, polycythemia vera, essential thrombocythemia, primary myelofibrosis. Number two, myelodysplastic, MDS, MPN syndromes, and acute myeloid leukemia. So this was myeloid neoplasms. Lymphoid neoplasms, how do we classify it? Precursor, like B cell and T cell. So precursor B cell, B acute lymphoblastic leukemia, and mature B cell, which has chronic lymphocytic leukemia, lymphoplasmacytic lymphoma, monoclonal gammopathies, plasma cell neoplasms, which includes multiple myeloma, hairy cell leukemia, marginal cell lymphoma, follicular lymphoma, mantle cell lymphoma, diffuse large B cell lymphoma, and high-grade B cell lymphoma. And then we have the precursor T cell, which has T acute lymphoblastic leukemia, and then mature T cell and NK cell, which has all these classifications in front of us. And then finally, we have the mixed myeloid and lymphoid neoplasms, which we have mixed phenotype acute leukemia. So you see from where we started from the classification, and we have come now to a very simple classification of these hematopoietic neoplasms. Why I did that? You remember our three diagnoses? So where do you find those three diagnoses in this classification? That was my main aim of doing it. So number one, we had T cell prolymphocytic leukemia here, and then we had mixed phenotype acute leukemia, and then we had primary pericardial Burkitt lymphoma. So they lie in this classification. And just to make a note of all these things, the first case was T cell prolymphocytic leukemia. Just some important points for that case. It is rare and clinically very aggressive. And important thing is that TPLL cells express CD52 strongly, as we can see in this case. And this is very important for the treatment of this leukemia because alemtuzumab is considered as the good treatment for it, and it targets CD52. And then expression of CD4 and CD8 is variable, and 25% of cases, they have double positive involvement, that is CD4 and CD8+, as we can see in this case. Again, these things we can see in this case. So that's how I just wanted to correlate this. And the next diagnosis we had was mixed phenotype acute leukemia. So I just wanted to emphasize that acute leukemia could be lymphoid, myeloid, or mixed. So that just depends on immunophenotyping. Acute leukemia is often myeloid or lymphoid in origin, and occasionally leukemia blasts can express both ALL and AML markers, which is defined as mixed phenotype acute leukemia. And about the third diagnosis, which was Burkitt lymphoma. So just to say that a lymphoma affecting the pericardium is very, very rare. But we had that in this case. The primary cardiac lymphomas are extremely rare. And this Burkitt lymphoma basically, it classifies as extranodal non-Hodgkin lymphoma. So like lymphomas are also of non-Hodgkin and Hodgkin types. And that is a very, very different discussion. And we are very short on time. And then it's a highly aggressive B-cell non-Hodgkin lymphoma. So yeah, this was my presentation for today. And these were my references where I used a Wikipedia image and I read the content from up to date. Thank you so much.
Thank you so much, Anmol, for the superb presentation. I think I myself, to be honest, always thought of leukemia in general as a very heavy topic. And I remember I had once like a presentation while being in school. It was like 150 slides. It was one of the most difficult I'd ever had in med school. So thank you for the superb presentation. You did very well. So I guess now we'll be hearing from our second presenter, who's Elena. So Elena, you have the stage. Feel free to introduce yourself to the audience and share your presentation.
Yeah, thank you so much, Ibrahim, for this introduction. I'm Elena. I'm a last year medical student from Germany, and it will be my first recap today. And before I start sharing my screen, I just want to say that I loved your presentation, Anmol, and I think you would be a fantastic future hematologist. I think I always struggle with the hematopoietic system, but it was really, really clear and so great. Okay, let's get it started. Can you all see my screen?
Yes, you're good to go on.
Okay, great, that's great. I only capture one case because three was just too much for me. So I'll be recapping Jasdeep's case from March 15 that was discussed by Robbie. So this is the case of a 49-year-old male with past medical history, only notable for myocardial infarction. And they presented with flu-like symptoms affecting both the upper respiratory system and the GI tract. The initial labs showed a new AKI and bicytopenia. On admission, this patient also reported of diffuse arthralgias. They had a fever, also hypoxemia, and on CT abdomen was notable for hepatosplenomegaly. And despite antibiotic therapy, the patient continued to have intermittent fevers and also developed encephalopathy. The team then repeated labs, which showed lymphopenia and hyperferritinemia, as well as hemorrhagic diaphysis. They also did a smear that showed mononuclear cells favoring blasts. And then they decided to also get a bone marrow biopsy that showed multilineage dysplasia and increased blasts. They repeated also a CT abdomen and chest that showed inflammatory changes in multiple organs. The lab trends showed a rising ferritin and signs of both activation of the innate and adaptive immune system being active. And okay, so let's take a break here, because if, like me, you are overwhelmed with all of this data and you are not able to see the wood for the trees, then the next slide is for you. So bringing it all together, we have a patient that presented with alternating multi-organ inflammation and fever without evidence of an infectious or autoimmune cause. The patient also had hepatosplenomegaly, bicytopenia, and bone marrow dysplasia and blasts. And in the labs, we found HLH-like findings. So before I will go into the details of the syndrome, I would actually like to make two teaching points that are relevant for the course of this case. So first, and actually this is true in any case that we see, if we have a patient with such an overwhelming amount of symptoms, we have to look for diagnostic specificity. And in this case, this could be fever plus hepatosplenomegaly. And I have listed a few of the differential diagnoses here. The second point that I want to make is that our patient had a very prominent hematologic imprint, which makes the probability of the other organs being involved secondary. Okay, I have to repeat this sentence. So our patient had like a prominent hematologic imprint, and the probability that the other organs being affected as secondary is very high. So they had like CNS findings, lung findings, and other sites of inflammation. And lastly, I would actually like to ask a question to the audience. There is one diagnosis that is very important to consider if you have a patient that has potential leukemia and overt coagulopathy. Maybe you can discuss that in the chat. So the patient fulfilling 6 out of 8 of the HLH 2004 criteria, we have confirmed that this is an HLH-based disease. HLH, however, is simply a signature of inflammation, like monocytosis or eosinophilia. So it is by no means a diagnosis, but it's an inflammatory fingerprint that can change your differential diagnosis. And we have to ask the question, what conditions have the HLH signature as part of their phenotype? I don't really want to go in too much detail concerning the scoring system, but we have to be aware that all of these like treatment and criteria, they mostly rely on pediatric protocols. However, both the HLH 2004 and H-score have like very good specificity and sensitivity in the adult population as well. It's of course kind of cliche to talk about HLH on CPS. However, I have decided to talk about this because I think it's one of these diagnoses, if you don't think about it, you will just not make the diagnosis. And it also has an extremely high mortality and is often confused with acute sepsis. Okay, let's take a quick step back. And as you attend CPS VMR, you probably know that HLH is a disease of excessive immune activation. So physiologically, once you've cleared an infection, of course, you would like your immune response to subside. Immune cells, namely macrophages that are no longer needed, are cleared by cytotoxic T cells and NK cells. And the problem is in HLH, these cells fail to eliminate the macrophages, which then produce excessive cytokines. This leads to hyperinflammation and finally organ destruction. As a side note, ferritin, just like hemophagocytosis, give you a great idea of how activated your macrophages are. And hemophagocytosis and hyperferritinemia are typical features of HLH. However, hemophagocytosis is neither necessary nor pathognomonic for HLH. Hyperferritinemia as well is really great and specific in the pediatric population. However, in adults, it more often occurs in the setting of renal failure, hepatocellular injury, infections, and malignancy, and is not really specific. To confuse us all a little bit more, the pathophysiology and thus the treatment of HLH is slightly different with respect to the underlying trigger. In HLH, which was the case in our case, in Jar's case, the malignant cells actually evade cytotoxic destruction and produce the cytokines themselves. So originally, HLH was divided into primary and secondary HLH. Because HLH is mostly a pediatric disease, genetic defects play a major role. However, those defects are increasingly found in adults as well, which may be explained by mutations with partial residual function. Interestingly, whether we find a certain genetic background or not, there's usually a trigger that we have to look for and treat. Generally speaking, the trigger in children is often an infection, especially EBV, whereas in adults, 45% of patients have an underlying malignancy. Interestingly, there is even like some immunodeficiency syndromes that disable you to clear EBV infections like XLP and X-Men that not only make you susceptible for severe EBV infections and EBV-associated lymphomas, but as you guessed it, also HLH. And even in patients with malignant diseases who develop secondary HLH, you usually find an infectious trigger. Often it's BK virus, HHV6, or EBV. At this point, I would like to ask a second question to the audience, and that is, how can you have, because like this is controversial, like how can you have hyperinflammation if you're immunodeficient? I will answer the question in the end. So most patients with HLH are acutely ill with multi-organ involvement, cytopenias, liver function abnormalities, and neurological symptoms. And the initial signs and symptoms of HLH may mimic common infections. This may also remind you of non-infectious inflammatory syndromes like Castleman's, TAFRO, MIS-A, or CRS. Above, I have, here, I have listed a few features of patients with critical illness that should make you suspicious of some form of immune dysregulation. By the way, liver dysfunction is the predominant organ dysfunction in these patients, while renal dysfunction is usually spared until late in their disease course. So this is my last slide. As mentioned, the patients are usually very sick and require an ICU level of support. And in general, there are two main targets to treat HLH. First, you want to inhibit the cytokine storm, and second, you want to ablate the T cells. The cool thing about the steroids is that they have a profound effect on the innate immune system, but in a dose-dependent manner, they can also cause cytotoxicity that ablates the T cells. Meanwhile, it's very important to start very aggressive upfront, and it's okay to have like a multi-layered therapy. And going back to what we discussed earlier, differentiating what triggers the HLH is very important because it will change your treatment, as you can see here in this slide. In Josh's case, the patient was ultimately diagnosed with high-risk MDS, meeting the criteria of bicytopenia, bone marrow dysplasia, and they also had like a P53 mutation that is like not so good for the outcome actually. And to answer the question that I just asked about how can you have hyperinflammation if you're immunodeficient, for example, in the context of chemotherapy? It's because of the immune dysregulation. So if patients cannot clear their infections in the setting of immunodeficiency, they'll have persistent antigen presentation and they continue to activate their immune system. It's a little bit like DIC where all those cells get consumed. So those patients end up not having enough CD8 and 9K cells to be able to control their immune response and to like kill, for example, macrophages. Okay, so I think to me, HLH illustrates the important principle that the mechanisms controlling innate immunity are critical to the regulation of inflammation. And as of today, we know that more subtle variants in these mechanisms likely contribute to the presentation of other much more common diseases. Yes. I want to thank Jas for letting me reflect on his case and for answering all of my questions. And thank you also to Ibrahim for your facilitation, and Mike, back to you.
Thank you, Elena, for this amazing presentation that did not only go into the diagnosis of HLH, I guess, but also the etiology, the underlying factors, and the treatment by the end of it. It seems that you've put a lot of effort into it. So thank you so much for sharing this knowledge with us. So now we'll be moving on to our last presentation for the day with my dear friend, Jimena. So Jimena, if you can share your presentation and introduce yourself to the audience. The stage is yours.
Thanks, Ibrahim. Before presenting myself, I just want to say that what amazing presentations both Anmol and Elena have done. Both of them covered really, really difficult topics, and they're definitely worth rewatching them multiple times. So right now for the last presentation, before that, I'm going to present myself. My name is Jimena. I'm from Guatemala, and I am an incoming intern this year. And I chose a topic that I'm sure that we're all going to see or have seen during our training. So let me share my screen. There it is. Can you guys see my screen? Okay, good. So for today's recap, I chose a case that was presented on March 29th. It was a case of weakness presented by Brandon Robinson, and it was discussed amazingly by Ravi and Reza. So first, we're going to start with a 78-year-old patient that was brought by his wife due to bilateral weakness in upper and lower extremities. And when we hear more about the story, we see that he has a new onset of right wrist pain and it's swollen. This has gone for a week and it has progressed. It has become more red, more sore, more tender. And we also have some fever and some rhinorrhea. And all this syndrome is accompanied by chills and progressive fatigue. With the past medical history of this patient, it was broad, but I wanted to highlight right now the most important things that I thought when I was looking at the case. You know, we possibly have a case of arthritis, and this patient has past medical history of gout, so we could be dealing with crystal arthritis. He also has this delta mutation that predisposes him to hemochromatosis, which we know that it's an inflammatory condition and can also present with joint pain and joint destruction. And last, he had an aortic valve replacement 5 years ago, which is always really, really good to know because they can be more prone to complications. And when we keep evaluating this patient, we see that he's definitely febrile, he looks ill, and we definitely have a right wrist arthritis because it's swollen, it has effusion, it has erythema, it has pain during movement. And then if we remember what the patient consulted for, he consulted for weakness. But when we see the neuro exam, it really doesn't show anything there that can point us to why this patient is having weakness. So this is a pivoting point for us to actually wonder, are we dealing with weakness that it's neurological in origin, or this is more fatigue? And this is very difficult for patients to describe it, but it actually changes our differential because we can have just a constitutional symptom that can be related to a million conditions, such as fatigue, and then we have neurological involvement. So it's important to just clarify with the patient, what is it that we're dealing with? And then when we get some labs, we figure out that this patient has leukocytosis, he has normocytic anemia. The chemistry really doesn't reveal anything, but then when we evaluate the inflammation markers, they're high. We have an ESR in 56, a CRP in 26, a CK in 390. So just recapping right now, we have a patient who has fever, who has arthritis, who has inflammation markers. So we're kind of like guiding our diagnosis on conditions that can cause that type of inflammation. And then as we keep studying the patient, they obviously decided to tap that joint, that wrist. And we see here that we also have leukocytosis, and we're also finding some crystals here. So we have one potential cause right now for that arthritis. But then how do we tie that with the fever, with the fatigue, with the chills? So we need to keep evaluating that patient because the patient can have two separate conditions at this point. And then we see that the MRI of the brain revealed severe small vessel disease. And what we know about severe small vessel disease, we know that it's usually chronic condition, but can be acute too. And we know that it involves the arterioles, the capillaries, and the veins. So far, we know that it can affect both the arteries and the veins. It can be chronic, but it also can be acute. So right now, we're going to put this just on the back to see how we can tie it up through the whole case. And lastly, this patient got two echoes, one transthoracic and one transesophageal, because infective endocarditis was a concern in this patient due to the prosthetic valve. And we see that both studies revealed that the valves were in good conditions, and there was no vegetation. There was also no deterioration on the past history and the past echo that the patient had. So just to do like a quick recap on where we are, we have a 70-year-old male patient with past medical history of an aortic valve replacement that presents with fatigue, with fever, with right wrist arthritis. We work the case, we see that we have inflammation markers that are positive, a normal echo, and an abnormal arthrocentesis. And we're still waiting right now for the blood cultures and the cultures of the joint effusion, because we're dealing right now with inflammation that can be infectious, can be autoimmune, even can be neoplastic. So those are the things right now that we have to consider. And one of the easiest thing, or would be also most common, would be to rule out infection. So the microbiology results came back, and both in the joint effusion and the blood cultures, we found Staph epidermidis, and in the blood cultures, we got 4 out of 4 bottles. So this patient was diagnosed with infective endocarditis caused by Staph epidermidis. So, but what about the echo? We're so used to getting an echo and finding something there that when it's not there, we kind of like are a little bit surprised about it. But the truth is that with this case, they did a repeat transesophageal echo after 10 days of the patient being in treatment, and it did reveal a vegetation and evidence of multiple embolic events. So we're going to talk today about infective endocarditis. This is an infection that it's in the endocardiac surface, and that's why we check the valves, because it affects there more commonly. But really, it's a multi-systemic disease because it not only can affect the cardiac system, but it can have repercussions on the pulmonary, the renal, and even the neurological system. So when we talk about bacterial causative agents, I found this meta-analysis that studied 33 cases. And if we just see it roughly, we see that Staph aureus is definitely the king. When we have infective endocarditis, the most important thing when it comes to bacterial infective endocarditis is to rule out Staph aureus. But then if we zoom in, patients with prosthetic valve, which is the case that we have, we see that it's actually coagulase negative Staph species that are going to be more common, which is also correlated to the diagnosis that our patient had. And if we see this epidemiology around the world, we're going to see that Staph aureus is still the king, except in Asia, when it's going to be more common to find streptococcal species than staphylococcal species. And when we talk about the clinical manifestations, endocarditis can be a very, very insidious disease. And I found this systematic review where they checked patients in Latin America, specifically from 10 countries. And we're going to see here that fever is by far, if you see the percentage at the end, it's by far the most common symptom that we're going to have, which is still very non-specific. We're also going to have malaise, and we're going to have a hard murmur. If we have the history of a patient and that patient reports a new murmur, that should be like a red flag for us to try to investigate if this patient's dealing with infective endocarditis. We're also going to see that it's very common, not very common, but a third of the patients can have a vascular phenomena, and it's going to come in a form of an embolism, most likely. And then we also can have a picture of sepsis in this patient, especially in older adults. And when I say older adults, I mean people over 65 years old. So what about the manifestations that we're all really used to learn in medical school and that are board questions? We have them here. We have the Osler notes, the Roth notes. We also have the Janewin lesions, the conjunctival hemorrhages. And if you see the percentage there, it's really low. So these manifestations, although they point us in the direction of infective endocarditis, the absence of them should not deter us to try to find this diagnosis, because it's really uncommon to find them. And if we have a patient who, besides the syndrome, has indication of having cardiopulmonary involvement, this patient can be dealing with a valve insufficiency, either by destruction of the valve per se or the leaflets, most commonly the aortic and the mitral valve. So these patients are going to present with an acute presentation of chronic heart failure. So if we have a patient who does not have a history of heart failure and it's presenting to us that way for the first time, definitely infective endocarditis should be in our differential of things to evaluate that can cause this type of destruction in the valves. So what about the diagnosis right now? We all know the modified Duke criteria, and actually they updated the Duke criteria last year. So we're going to review a little bit of that. We can have the modified Duke criteria just give us like a high likelihood of the diagnosis being infective endocarditis. So if we have these things, it's the probability of having infective endocarditis is high. That's what we need to keep in mind right now. So we can do the diagnosis either through pathology, or we can have a different combination of major and minor criteria. We can do the diagnosis if we have 2 major criteria, or we have 1 major criteria and 3 minor, or if we have 5 minor criteria. So you can see here that the diagnosis of infective endocarditis is dynamic, and they try to adjust to the different presentations and also the different resources available in different parts of the world to make the diagnosis. So with the major criteria, I try to put it in buckets, so it's easier for us to remember because there are a lot and they can be overwhelming. The easiest one is going to be the pathologic criteria. If you get a sample of heart tissue for whatever reason, and then you find microorganisms in that culture, you can diagnose them even by culture, by staining, by PCR, but if in that piece of tissue you find those microorganisms, you got the diagnosis there. When it comes to the microbiologic criteria, we're talking about blood cultures. So if we're talking about a common organism, you only need 2 separate blood cultures. If it's an uncommon organism, you need 3. And they added also this lab tests that if you read them, they're going to be related to bacteria that are known to be difficult to identify and that are causes of infective endocarditis, just like Coxiella, Bartonella, and Trophorema. Then you have the imaging criteria. You can either do an echo, a cardiac CT, or a PET CT. So if we have an echo and a cardiac CT, we just need to find evidence of a vegetation or either a perforation, an aneurysm, either on the valve or the leaflet, aneurysm, an abscess, or a cardiac fistula. And one important thing here is that if you find a new significant valvular regurgitation, that should also raise alarms for you, which is why we also look for it in the physical exam. And then in the PET CT, if you have abnormal metabolic activity, either on a native valve or a foreign material like a prosthetic valve or an intracardiac device or any type of wiring that those devices need, that would also count as positive. And lastly, they also add the surgical criteria that it's just basically by observation. If you're doing cardiac surgery and during the direct inspection, you see that there's something wrong, you can put the label of infective endocarditis on that patient and treat it promptly before getting all of the microbiological and imaging criteria, which can also help the patient for the survival if you do give prompt treatment. And then we're going to have the minor criteria, and I'm not going to read them all because there are a lot. But when we talk about predisposition, you know that having a prosthetic valve it's one minor criteria, and it's one really important risk factor to have infective endocarditis. We can have vascular phenomena and immunological phenomena, and I try to highlight the things that our patient had. So we had the blood cultures, which was the major criteria, and then with the minor criteria, we had the prosthetic valve, we have the arterial emboli, because remember that we had small vessel disease on the brain MRI, and then the fever that was documented. So we really don't need an echo to do the diagnosis of infective endocarditis, just for you guys to know that if an echo comes back negative, we can't fully rule out. We just have to look for other minor criteria or major criteria to see if it fits with the diagnosis. And then lastly, they added as minor criteria incomplete positive tests. And let's say that instead of 2 blood cultures, I have only 1 that was positive, then that would count as a minor criteria. So what about the TTE and the TEE? You know, that's a question that we all ask. And they did a meta-analysis that included 2,000 patients, and they evaluated if they had, they included, patients with and without prosthetic valve. And what do we know about this? We know that if we have a patient with a native valve, we can do a TTE and it has a good negative predictive value. So I have a patient with a native valve, the echo comes back negative, the transthoracic, the likelihood of being infective endocarditis is low. However, if I have a patient with a prosthetic valve and the TTE comes back negative, it has a bad predictive value. So I cannot rule out that patient has endocarditis. So I need to do the TEE to confirm it. It's kind of like the gold standard for patients with prosthetic valve. And when it comes about the treatment, it's beyond the scope of this presentation because it's really long. But the last thing that I want to leave you guys with, and in the spirit of working with different specialties in medicine, what about doing an aortic valve replacement, transcutaneous or with open surgery? They used to think before that if we did an AVR during the open surgical approach, these patients would have like more risk to develop infective endocarditis because obviously you're open, you know, the cavity, you're exposing it more versus just doing it transcutaneously. However, this systematic review, let's hear the reference down there, prove that there's really no difference in the incidence of infective endocarditis between both surgical approaches. So it's really important to know that, and that just take into account that an AVR is the risk factor, regardless of how it was done in the patient. So these are the reference, and I hope that you like the presentation. Thank you so much.
Thank you so much, Amina, for your presentation and for all the beams that you've actually had during your presentation. You've introduced us to not only to the case itself, but also to how infective endocarditis can have different presentations and how you should suspect infection if you have the very least of one of its symptoms. So thank you so much, Jimena, for this amazing presentation. Before we leave off, I just wanted to remind everyone that in 45 minutes, we will actually be having another VMR at the intern bootcamp, where we'll be learning more about approach to chest pain and troponin elevations. So we hope we can see you there as well. I think the VMR leadership has actually prepared for us an interesting session. So please don't miss it out if you can attend. So thank you all for being here today, and hopefully we can see you on more TP recap sessions.